Welcome to the Fresh RN podcast. The information contained in this podcast is meant to supplement your existing knowledge and not replace it. Always refer to your state board of nursing, standards of care, and respective institutions' policies to guide your practice. All identifying patient details have been changed to protect their privacy and remain compliant with the Health Insurance Portability and Accountability Act of 1996. Thanks, nurses. Stay fresh. All right, welcome to the podcast. I am Katie Cleaver.
And I'm Elizabeth Mills. You're listening to the Fresh RN podcast. Thanks for tuning in.
We appreciate you. Today we're going to talk about something a little somber.
Yeah.
A little serious.
Yeah.
Death.
Patient deaths and caring for the dying patient, which you will see as a nurse.
Absolutely. No way around
and I think we're going to kind of go into, Katie's going to share a story. We're going to go into a little bit of the physiological aspects of what's happening when a patient is actively dying. Talk about some of the resources and things we should use to help caring for the dying patient. And then kind of describe what our role, a nurse's role, should be with caring for the patient and their families. And then we'll talk a little bit about what, how we can care for ourselves, because we see death a lot, and we might get a little emotional.
We pre-apologize, but
yeah,
not sorry if we cry.
But yeah, it's a, I don't know, it's a touchy subject. So anyway, all right, Katie.
So, and I want to preface too that we're going to talk about, this is not the coding patient that we're trying to heroically save. This is the patient that is passing away. All right. So I'm going to start off with a story. It was a normal day in the neuro ICU. Actually, it was a little abnormal in the fact that I only had one neuro patient. I was open for an admission, and my patient was doing just fine. And I was kind of hanging out there and kind of waiting for the impending admission. And then all of a sudden I heard that was a code blue was being called overhead. And I actually was sitting right next to the rapid response nurse. It was not Elizabeth that day. It was somebody else. But I was like, hey, I'll go with you if you want. Because it's nice to have another set of ACLS prepared hands when you're going to a code. And the code was called, I believe, on the oncology floor. And for those of you that will or have worked in oncology, there's a lot of death in that unit. Probably just as much as the ICU, I would think. And I remember, that feeling going up to the code, like, okay, like getting like a little mentally prepared for it. You know you're going to get off the elevator and go to someone who's actively dying. It's kind of surreal to kind of stop and think about. So that I'm riding in the elevator, and then, you can't really run in the elevator. So you're just kind of standing there waiting and ready for it to, the elevator to open for you to run to where you need to be, because you need to be there that quickly. So we run to the unit and we see that the doctor had caught up with us, and we decided, we were walking into the room, and I see the patient in the bed who actually looked deceased, honestly, and a husband yelling at the nurse, and I see a DNR wristband on the patient.
Do not resuscitate.
Yep. And meaning if this patient is to start dying, don't code them. So what ended up happening was this patient had a long-term history of cancer and was in the terminal stages, and death was pretty imminent, but the husband wasn't like ready for what that would look like. So when she stopped breathing, he kind of freaked out and demanded that we intubate her, even though her cancer was actively killing her. And she was a DNR, but I don't know if he really understood what that meant. So the last moments of this woman's life were not spent by her husband, like, kissing her forehead and holding her hand. It was him being held back by security because he was screaming at people and we were trying to communicate, and then he suddenly got violent. And that is how death can look. It doesn't always look like hey, holding your hands and slowly exiting this world peacefully, it can look pretty not peaceful in the hospital.
Yeah, it can be a little bit of a chaotic moment, and especially when families are dealing with the emotions and coming to the realization that this is actually happening.
Yeah, and it was one of those moments where I'm standing in the room and I'm like, am I actually seeing what I'm seeing with my eyes? And it was kind of like the doctor didn't the doctor kind of tried to take control and by explaining to the patient and being that voice of reason, and did a good job.
Explaining to the husband.
Yeah, like I could throw a breathing tube down her throat, but it's not gonna. We're just gonna take it out, and she won't be breathing again. And one would have thought that her oncologist, and I afterwards kind of got the impression that maybe the oncologist had, but it hadn't really hit the man. That she is, this isn't going to save her life. It's just going to prolong suffering. And seeing him realize his wife is dying while 4 strangers are looking at him and someone in a uniform is like ready to, protect everyone's safety. And he's just like started like awkwardly crying because it hit him. And it was like, oh my God, my heart. Like, I can't believe I'm watching this right now. And I don't know the name of the patient. I don't know the name of this guy. And he's just like this big, taller kind of guy, like crumbling. And it was really humbling. And me and the rapid response nurse kind of comforted a little bit, asked some questions, got him something to drink, gave him some privacy, and made his wife kind of fluffed her pillow and covered her up. And we had to go back to work. Yeah. And that's
carry on.
A death story.
That's the hard part about sometimes seeing a patient pass away is it could be at the beginning of your shift, the middle of your shift, and you're like, okay, this has happened.
You still gotta work.
All right. Yeah. You gotta keep putting one foot in front of the other. So some of the things this is another thing that as you see more and more of these experiences, you'll start to learn the patient's breathing patterns, color changes, things like that are taking place with a patient who's actively dying. But it's so important to educate the family members and the people who are present about what is going on with this patient, what they're going to see, what they are seeing, and what we can do to help that patient be more comfortable. Mm-hmm. And in a sense, I feel like some of these interventions aren't necessarily for the patient, but maybe just for the families to have a little more peace of mind to say, okay, my loved one is not suffering. So there's things like you always hear, they call it the death rattle, but it's like a really, it's a rattle that you don't really hear any other time.
I wonder if you Google or you YouTube death rattle, I bet that would come up with something. Like, I mean, it's pretty distinctive. And when we say actively dying too, it's not like, oh, okay, they've got this stage 4 cancer diagnosis and they're going to die in 2 months. It's like the patient's oxygen, their oxygen saturation is dropping, and they're, it's not like they're on their last breath, but they can't keep this up much longer kind of thing. Yeah. I had, actually, that made me think of another story talking about educating the patients. And it's really important, to educate the family about what they're going to see so they don't freak out. Right. Because you don't want that patient dying and then a patient's family member freaking out, and you got to take care of both. Right. That's really challenging.
And you're still going to you are still going to see that breakdown of emotion from time to time, but you can do the best you can by preparing them for what's in store. Mm-hmm. And that may help sort of break some of that sort of chaos that can and like we said, this is somebody who's actively dying. It's always a little different when someone just unexpectedly codes and dies. That's always a little different. Yeah. It's usually always different, but this is, it's so beneficial to help prepare the families. And
Yeah.
I just take extra special care in saying, okay, this is what's going through their IV. This
Mm-hmm.
is what we have. They're getting, they're getting pain medicine. This is what we can use for this, this, and this, because the patient who's passing away is usually probably not really responsive.
Mm-hmm.
They are just in a very deep sleep. And I always say deep sleep because I feel like it just provides more of a sense of peace to the family.
Absolutely.
So you have to be just very careful in the words you choose and the delivery and what you're doing. And I just try to be very, very tedious and careful with what I'm saying to the family.
Yeah, that reminds me. That first story, I had kind of just walked into it, but one more recent story was I had a patient, and we see this frequently in ICU settings, particularly neuro ICU, where a patient has this profound neurological injury that's unsurvivable, whatever the word is. But so I had a guy that was like that, and the family, he was on a breathing tube. We did all the scans and all the yada, 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 and figure out, I think it was a bleed. I don't remember. Some massive neuro injury.
Head bleed.
Yeah, he wasn't brain dead, but he was pretty close.
Yeah.
So the family made the decision, we're going to remove the breathing tube and let him pass naturally. And we were waiting for someone to fly in. I feel like that happens all the time. We've got somebody that's about to actively die, but we have to wait for someone to fly in. That's happened a lot, actually. But that was the case, and we were waiting for a daughter or somebody to fly in from across the country. And so I made sure to educate the family a lot. Okay, so he, and I based some of my education off of his neuro assessment. Like, there were a lot, he wasn't responding to pain neuro-wise. So I was like, this guy can't tell that he is uncomfortable. He cannot tell that he's got a breathing tube in. Like, he had no sedation, no pain meds, and he's kicking it on a breathing tube. So I felt very confident in my ability to educate the family that he's not experiencing suffering right now. So I made sure to educate not just the wife, but the kids and their spouses, adult children and their spouses, about what to see and what to expect. I kind of, when you kind of meet people in that situation, you can identify who's going to be a little bit more emotional and who's kind of the strong, and you kind of tailor the stoic person. And so what I did was, every time I went in the room, I checked on the patient and treated the patient like he could hear me, even though I knew he couldn't hear me.
Right.
Like, I'm going to turn you now, and here's this, and da-da-da-da-da. And then always made sure the family had some coffee or some water and some tissues. Always made sure about that. Asked them if there's anything I can do. I don't know if they wanted a rabbi or a priest. I don't remember, but I got whatever spiritual leader they wanted there. We took out his breathing tube, and he actually... I thought he was going to pass pretty quickly, but it ended up being a whole day.
Wow.
So,
and you never know.
You never know. You think like people are going to die right away.
There's no magic number.
Right. And of course, the second you tell someone, oh, it'll be quick, then it's going to be 3 days.
I try not to tell people when I say, we just don't know yet.
I learned that very quickly, that you don't ever give people a timeline, because the patient is not going to do that.
That's sort of out of our control.
Completely. So he ended up lasting, and I made sure to get a night shift nurse that had a hospice experience. So I made sure that nurse took care of them over the night. Told him to expect, the snoring, and apparently he snored at home or something like that, and so it was even more profound because he wasn't protecting his airway, and it was going to be even worse. So made sure to know to expect that, to not be alarmed by that. I turned off the alarms in the room, so they wouldn't hear those, and I educated them in what to expect, and what medications I was giving to make it so the snoring wasn't so loud, and he seemed more comfortable. And then I came back the next day, and he was still there, but I got floated, actually, so I couldn't take care of him, and I got floated to another ICU. And I'm going through my normal work day, trying to get my mind around what's going on with this couple patients that I'm not used to, because it's like a different ICU. And all of a sudden, my manager comes and says, hey, the family of that patient that you took care of yesterday wanted to talk to you. I'm like, oh my God, what did I do wrong? That's my first thought. Oh my God, what did I screw up? And they're by the door, like sobbing. I'm like, oh, great. So he had just passed an hour earlier, and they wanted to come over and thank me for the care I gave him. And I really appreciate that.
Yeah, of course.
Because I didn't feel like I did anything really like special.
Right.
It was just kind of normal to me, but it spoke very deeply to them. And they found me in a different area of the hospital to say thanks.
I think that's key is, you know, you're really kind of taking care of the families in a sense. Sometimes not, almost more than the patient. I don't want to say that, and that I don't want that to come across as the wrong way, but you know, that patient's going to pass away, and these families are left here with us on earth, and they're going to be dealing with a lot. They're dealing with a lot, and then they're dealing with this grieving process and stuff like that. So I think it's really our goal to help them be as comfortable as possible, you know, and help them be as comfortable as possible means keeping the patient as comfortable as possible. So let's talk a little bit. Let's kind of go into hospice. There's lots of resources that we can use to help us care for the dying patient. Palliative care / hospice is kind of a big deal now in hospitals. We see it more than I feel like we used to, especially palliative care. But I know in the ICU setting, when we have patients who are, you know, not making it, we're doing everything we can, and they're just not pulling through. A lot of times our physicians will order palliative care consults, and they are a wonderful group of doctors, nurse practitioners, nurses that will come and just kind of sit with the family and meet with them and say, okay, this is what's going on with your loved one. You know, do you know what your loved one's wishes would be? We're kind of at a point of no return. You know, what do you guys, what are going to be some of the next steps? And they really do try to, I think they really do try to get the patients to thinking about, okay, well, you know, does my loved one want to be potentially hooked up to tubes and machines for the rest of their life? Or would they rather, you know, want to have more of a peaceful passing? And that's probably a whole nother podcast, but
I do want to quickly differentiate between hospice and
palliative care.
So, because sometimes people kind of use those as the same word, but they're not.
Right.
Palliative care. So hospice is this person is dying.
Yeah.
They've got, I believe the definition is 6 months or less. Correct me if I'm wrong. I think so, but it's like there is some sort of disease process going on that this is going to end this person's life in a certain amount of time. Palliative care, however, is a little different. You don't have to be dying to utilize palliative care, but it is frequently utilized. And hospice and palliative care typically work hand in hand because there are a lot of similarities. But one of the main differences is palliative care, and it's especially awesome in critical care, where they can take a look at everything that's going on and say what's important and what's not.
Yeah.
What interventions do we need to continue doing and what not?
Right.
Like one example, we had a patient that had a large brain tumor, a glioblastoma, I believe. And it was one of those that they resected it. It was just going to come back. And we were constantly checking this girl's blood sugars on the inpatient. We didn't have like she's definitely going to pass by this date, but it was like we were constantly checking labs that were kind of unnecessary, that weren't going to change her outcome. And they were probably adding suffering that didn't need to be there. So, you know, we had palliative on board anyway, and they were like, you know what? Why are we doing this? You know, can we stop doing this? Is this going to change the outcome or make her death sooner? Yes or no? No. So
right.
let's figure out what we can cut out. And there's a lot of, you know, that's just a very specific example, but you know, people don't have to be dying to receive palliative care, but honestly, a lot of it really does go hand in hand. And it's wonderful. There's a lot of research that shows that palliative care consults upon admission to ICU really improve outcomes.
Yeah, and I think, and what they can do is they sometimes just take a lot of time to talk to the families. Mm-hmm. Time that physicians, the ICU docs, et cetera, may not have necessarily time to do.
Yeah.
And sometimes, families are like, I'm not ready to hear this yet. This is not where we are, and that's okay. But, and palliative care does not mean this patient is going to die, but maybe this will help establish boundaries to say, you know what, we're okay with them, getting, IV fluids or tube feeds, but if they have to have another breathing tube put down their throat, we don't want that.
Yeah.
They kind of help
Figure that out.
figure things
I
out.
think it's complicated.
Everything's complicated, and you're talking about multiple organs in a lot of ICU patients that are affected. So you have different doctors, and they will sometimes just put the big picture together. So they're so valuable in the acute care setting, in our hospital setting. They make such a difference, and they're sensitive and kind, and that's a lot of them have hospice backgrounds essentially, but
I feel like the earlier they're brought on, sometimes like the better people deal with this. But I've found, and maybe you can tell me if you've had different experience, but surgeons are much less apt to consult palliative care in my mind.
I think some surgeons, I don't know if that's all of them.
I think
it depends on what's going on with the patient.
Yeah, I guess I feel like if someone is dying or whatever and they had surgery, it's almost like admitting defeat, I guess. Like if you bring on, because palliative is different than hospice, and regardless of if the patient survives or not, maybe they'll have profound disability, and palliative would have been a good idea. But that's just kind of my experience. Maybe I'm interested to hear, you as a listener, your experiences if you've seen that. But I'm a huge fan of palliative care. Another resource that's wonderful are chaplains.
Yeah.
I love me some chaplains.
Yeah. And I think, to kind of back it up, I think it's important to know your patient's culture, their religious background, because some families will call in their own, minister, priest, rabbi, etc. But sometimes I'll just call the chaplain and say, "Hey, this family, says they don't really need any chaplain assistance, but could you just come up here?"
Yeah, I need your presence.
Yeah, and they are so willing to do that. And they're not there to talk religion or anything like that. They're kind of here just for spiritual health, I think.
You know what? Gloria. I love Gloria, the chaplain at the hospital I was at, but they're also there to support you as a nurse as well.
Yeah. I use them a lot for me.
Oh my God. I had one where I had a younger man who was dying from a stroke who had children that were not horribly younger than myself. And I was barely keeping it together because he was actually unstable and we were trying to figure out if he was dying. So I was like very technically busy, but I was also trying to keep at bay. Like, dude, this guy's not that much younger than my dad. Like,
Right.
So I was trying to deal with that, and she came up just to check on the family. And then she came up to me while I'm trying to frantically chart. She's like, "I'm just here to check on you too."
Mm-hmm.
And I about lost it into my EHR or like,
EMR.
Gloria, don't do this to me now. I can't.
Yeah. Well, and that's, they do so many things in the hospital, but don't forget they are here for the medical staff as
Absolutely.
well. Other good resources, case management, especially if the patient is actively dying and could be sent home. They help line up hospice help, I believe, if that patient's going home with hospice. Child life services, which are amazing group of people in the adult setting, in an adult unit. If you have an actively dying patient with young children or children, they can help come talk to the children and help sort of educate them as to what does mom and dad, or sometimes grandparents, aunts, uncles. I've seen it all over.
Yeah.
They will come and help them explain kind of some of the things that are going on.
Yeah, like the ventilator or something like that.
And they do it. They know the child lingo.
I have a good little quick thing. I had a patient that had younger children, and that just walking into the ICU for a young child can be very traumatic. But it was a mom was dying, and the child life person got out little those Crayola hand things, and imprinted mom's hand. And got one for each of the kids.
Yeah.
And the kids did it. Like, they made the hand. And, oh, God.
Yeah, that's when you start to lose it.
Oh, yeah, that was rough. Ugh. It's like a part of it, but it's like, oh, my God, I can't deal with this right now.
The handprints they're really good at. And they also work with pediatric patients in the pediatric units and all
who
that.
They themselves are passing.
Right. They're pretty awesome, and I don't ever hesitate to call them if we're dealing with young patients or patients with young children, friends, etc. And then something that we kind of have to do when you have a patient who's actively dying is contacting the organ procurement group, whatever it is in your area. It's a part of policy. I know in the state of North Carolina, it's mandatory. You have to do it.
I would think in most states. So basically, just to explain that real quick before she goes into it, is families must have the option to donate the patient's organs. Whether or not it's determined yet if the patient is eligible to do that. Like, legally in the state of North Carolina, I would argue probably a lot of other states, you have to notify whatever your local organ procurement team or organization is to let them know, hey, I have a patient whose Glasgow coma is less than 5. They're on a breathing tube. They've got massive neurological injury or whatever. And that way they can do this screening and go from there. And it's a big deal if you don't let them know.
Right.
Because I did that once.
It is a big deal.
And I was able to get it situated, but it could have been a big thing. Because at the end of the day, if you don't notify this team, the family could potentially be denied the option of donating their loved one's organs.
Yeah.
And once you get to a certain point, you can't do it anymore.
Right.
And you can't deny that to somebody.
And if you're an organ donor on your license, there's all these laws, and I don't want to get into the big organ donation subject, but it's part of what we have to do with. And there's criteria. Mm-hmm. And in orientation, you should learn about that criteria and what you need to do.
Especially if you're in ICU.
Especially if you're in ICU and on the floor. But a lot of that was something I felt like I didn't get in orientation. And then, I had a patient that passed, and I needed to call them, and I'm like, what's this?
Who are you?
So, anyway.
And one other practical thing I wanted to mention too, and something to just kind of mentally prepare yourself for. A lot of states enable, with a doctor's order, that nurses can pronounce patients dead.
Yeah. So you don't have to call the doctor in the middle of the night.
Yeah. So, like, if you know a patient is imminently dying and they're going to die tonight, like, I don't need to call the doctor to say, hey, the patient died. Can you come pronounce them dead? Like, the doctor can, depending upon the state, and in the states I've worked in, this is the case where they can put in an order that says RN may pronounce death. And so the policy would look different at whatever hospital you're at, but my experience has been you and another nurse have to simultaneously auscultate apical pulse for 1 full minute, and if you do not hear any heartbeats, then you pronounce them dead at that time. And it kind of like TV shows, time of death, blank. So that may be something. I've done that quite a few times. I don't know about you, Elizabeth.
Oh, yeah. I think maybe only a handful of times a physician's actually been present when a patient has passed.
Yeah, and
pronounced it.
And that's typically an actively coding patient because it's their discretion to stop the code half the time. So if it's a patient they're going to die, most of the time the nurse is going to pronounce them. And I've done that many times. So that's something that I had no idea when I became a nurse I would be pronouncing people dead. But I have done that, and that's just kind of part of it.
Yeah, and you learn to do it. And there's also things to know. You need to be familiar with the paperwork or what needs to be filled out and completed in the electronic medical record. A lot of times the families don't need to necessarily give you funeral information, but they're going to need to call the unit or call you or call whoever handles the morgue downstairs.
Yeah.
But one thing that I learned, and I learned the hard way, I had a patient who passed away who needed to go across state lines. They
That's a headache.
wanted to be, or their family wanted them to be buried in South Carolina, and there's like a special form for that, and the death certificate needed to be completed before they left. And I didn't know this. It was a little bit of a cluster. So just be familiar with paperwork that needs to be filled out.
Yeah, and the death paperwork, you know, it's not like
complicated.
the family's going to come back the next day and you're going to be able to get them to sign stuff. Units I've worked on and many units I've seen have specific packets or like a workbook, so you go through step by step to make sure you get everything because the paperwork's so important.
Right.
Because a lot of times, like, the physician may not have time or won't fill out the death certificate until later.
Right.
And most of the time from the family, you just need like a signature or two and what funeral home they want to go to. And you as the nurse have to facilitate that. So you have to like call, you know, if you need to call the medical examiner, if you need to call the house supervisor, if you need to call the morgue and bring the patient, you know, and this of course is after you perform postmortem care, which is another thing. You know, and finding out if it's a medical examiner case.
Right. And there's criteria for that.
Yeah, which will probably vary on state to state. But, you know, typically if a patient is going to be seen by a medical examiner, you can't remove any lines or tubes.
And then, you know, like kind of going back to knowing the patient's culture. I know in this area of North Carolina, we have a very diverse population. We have a lot of people who are from the Southeast Asia region, and they have very particular practices with their culture and with their faith. And one thing that I learned, we had a patient once who passed who, I don't remember which religion they were with, but in their religion, if a patient or a loved one passes, the body can't be moved out of that room for like 3 days.
It can't be touched first. I remember, I don't know if it's the same one, but yeah, they're probably different ones. But I remember one where it was like we could not physically move or touch the body for a certain amount of time. Yeah.
And unfortunately, in the hospital, you can't do that. So that has to be something that's discussed with the family. And
you know, once, and it's interesting, I had a patient who they weren't actively dying, but he was I don't remember which culture it was, but we weren't allowed to put any white sheets on him because they associated that with death, which I thought was very interesting. So I thought that was interesting.
I had a patient who was Native American recently, and family had said, well, can you cut some of his hair and give it to me? And then someone came in and said, absolutely not. Do not cut any of that hair. That is like their I don't know.
Something that, like, very spiritual.
It was spiritually related or whatever. And I was like, oh my gosh, you know. And
I'm so glad I didn't do that.
but I mean, you know, so those are things to kind of pay attention to.
Yeah, like there's a lot. I've had people from various religions that have very specific beliefs, and the important thing is to ask. Like it's don't feel like, oh my God, how do I have to know this ahead of time? But if you ask in a non-judgmental way, like, hey, I want to make sure that we're appropriately acknowledging and doing whatever it is you want, and I might not be aware of it. So can you let me know what kind of practices that we need to be aware of? And just asking,
and that should
like,
be established
when
a patient comes in. It's usually part of the admission assessment, but you know, lo and behold, we're here. And so kind of going back to more of what a nurse's job is, there's some good medications out there to make sure patients are kept comfortable. Morphine, let me tell you, morphine is an excellent pain medication / bronchodilator / it does so much for a patient who's actively dying. More than just managing pain, it helps their breathing and things like that. So
in lots of different ways too. Man, hospice nurses are awesome with the different kinds of concoctions and like, you know, maybe not IV but sublingual or whatever. Like there's so many options out there.
Ativan is a good medication if patients have a lot of secretions. There's Robenal.
What about scopolamine? Is that one?
Scopolamine, those are patches. And then I think I've seen atropine given.
Oh, really?
Or maybe it's I don't know, for help with secretions to kind of dry out the mouth, because you're going to be dealing with a lot of secretions, and it really bothers patients' families when they feel like their loved ones are suffocating.
Oh yeah.
But once again, it's more of what they are seeing happen and less of what the patient may necessarily be feeling.
Mm-hmm. Let's go into some emotional support that we can provide to the family.
Okay.
Like, I think there's a few things, because I don't know about you, but whenever I had patients that were dying, and maybe they were doing okay and dying peacefully, but the family's losing their mind.
Yeah.
Or maybe they're not, and you just don't know what the heck to say. I just want to encourage you that
it's okay to say nothing.
It's okay to say nothing. I used to think like I had to say the perfect thing, but you know what? Nothing I say is going to change this situation.
Right.
Nothing I say is going to take away this emotional pain or make it be so comforting that they're going to feel so much better. Patients' families don't want you to fix the problem. They really just want you to feel with them. And that's
a good point.
Just empathizing with them. Like, I'm really sorry that you're going through this.
Yeah. And empathy is so important versus sympathy. And Brene Brown is one of my heroes, and she talks about empathy and sympathy all the time. And her comparison of the sympathy and empathy, if you've never heard of Brene Brown, you should go on YouTube and
do sympathy versus empathy. Brene
like a
Brown.
Cartoon.
Oh, it's wonderful. Like, sympathy is kind of looking down at someone and their problem and say, "Oh, that sucks to be you," but empathy is sitting next to somebody saying like feeling with them, feeling their sorrow with them, feeling their pain with them. But an aspect of that though is, I don't know about you, but I can't do that with every single patient because it's too much emotionally for me to be able to empathize to the core with someone in one room and then go in the next room and motivate this guy to walk for the first time.
And be in a good mood and be happy. And
I can't be all things to everybody. And actually a while ago I wrote a post called "I Wish I Could Cry With You, But I Can't." And and I'll put a link to that at the bottom of these show notes, but it was kind of trying to verbalize that struggle that I think a lot of nurses have. Like, I can't emotionally get to this point to crying with this particular patient right now, because it's too difficult for me to go from room to room.
Yeah.
And a lot of nurses, I think, identified with that. And then a lot of people also hated on me for that.
But it's true. I mean, it's, once again, you kind of have to know your own spiritual, emotional awareness. And, we still have a job to do. So,
if I'm sitting in one room empathizing and like losing my cool and my like going to that place emotion, I know like if I get to the point where I start sobbing, like it's going to be really hard for me to pull myself together to get to the next room and give the meds that I need to give and do the kind of things I need to do. So I can't be all things to everybody. No. So I just want to encourage you as a new nurse, don't feel, I want to encourage you to not have that pressure that I put on myself to say the perfect thing to the family, but just to really sit and feel with them. Make sure they got their tissues. Give them like a reassuring, like maybe pat on the shoulder or like I'm really sorry. Like that, I just saying like, I'm really sorry, and not following it with, at least he's comfortable, or at least this, like trying to avoid that kind of stuff and just really trying to kind of be present in that moment with them. Right. I think is what people really appreciate. And if you don't know what to say nothing and just take real good care of that loved one.
Right.
Because at the end of the day, that's what they want.
And don't do things that are unnecessary. They don't need their vitals done every 4 hours. They don't need blood sugars, like you said. They don't need unnecessary sticks. I think it's important to take care of their skin, still turn them, keep them repositioned, covered, lots of pillows, and sometimes it's just good to be present. I had a young man who had a really bad stroke earlier this year, and it was so difficult to be with this family. This patient had a stroke and was locked in, which means literally he had his only way of communicating was with eye movement, and he had made it clear that he wanted to be let go. He wanted to die, and so we honored his wishes, but I remember the children had stepped out, and I just sat with the wife. Yes, I had another patient, but I did get emotional with this because I just sat with the wife, and she came back. She came back the next day after the patient had passed, and she had to get some of his belongings, and she just said, thanks for sitting with me. And sometimes that's just all you have to do.
Mm-hmm.
And I always say, can we get you, we have chaplain services. Can we have someone come talk to you? Because no, you can't do it alone. You need to rely on help, resources that can help you, take care of the families. But kind of going into taking care of us as nurses with actively dying patients, I talked about spirituality. I think it's important for us as nurses and working in healthcare to kind of feel comfortable with our own spiritual awareness. And
Mm-hmm.
I'm not pushing religion or faith or anything like that, but this is oftentimes a spiritual situation. So I think it's important for us to know kind of our own beliefs,
Mm-hmm.
feel comfortable in our own beliefs.
And feel comfortable with those that have very different beliefs.
Right. Knowing that you are, no matter what, you're a big help to these families, especially even if it doesn't seem like it. I hate this sounds terrible, but I feel like in our job, we see life begin and we see life end. And I feel like it's a privilege because people don't get to see that.
Yeah.
I feel after seeing people pass away, it's really funny. I'm not as afraid of death as I once was. I don't know. I just I don't know. I don't know how else to explain it, but
I think, though, it's important to be able to do this every day or 3 days a week.
right,
It's important that we ourselves figure out what we think about death
right,
and what we believe happens when somebody passes.
mm-hmm.
Because I feel like that might be one of the few ways to like be able to continue doing it.
Right.
Because otherwise it gets pretty jaded, I guess, or pretty like, I don't know, it's hard to find.
No, and gosh, you've got to learn to laugh. I mean, talk about nurses having odd senses of humor. I mean, you've got to laugh.
Yeah,
When it's said and
weird.
done, not at that moment, but you've got to be able to go somewhere and laugh.
Like
about
hopping out of a body bag or something like that.
Right. Yeah. I mean, yeah. I mean, find humor and that sort of helps, and rely on your coworkers. And
I think too, when you go through a tough one, because some of these patients are going to get to you more than others. It gets you in a good way, I guess, not gets you in a bad way, but you get emotionally invested. And I think it's important for you to have a support system to be able to talk about it with. I've had a couple patient instances where I go home and I just sob on my husband's shoulder.
right.
Or whomever.
Yeah.
And I had some where I had to really talk it out with some people and get, my own spiritual kind of healing through it so I could continue to be the nurse I needed to be the next day and not become so wounded by it that it didn't make me better, I guess.
Right.
I don't know how I want to say that, but so to be able to continue to do it and to be able to have some level of empathy and authenticity with our patients, we have to we can't just like walk through this. Someone's literally worst nightmare. The worst day of somebody's life is our day at work. And we have to have a way to be able to
Right.
process that.
Right.
Otherwise you do turn into like jaded, angry, and you do out of a survival out as a way to keep doing it every day. So I encourage you to kind of, if you haven't started working on that kind of spiritual development for yourself, to really do that, because I don't know how long it'll last without some sort of ness of that.
I actually went through a really sort of life-changing situation a few months ago with a patient, a young girl who was in a car accident, who she didn't make it, and she was in our unit for about a week, and I took care of her every day I worked, and she had just an amazing family, probably one of the best I've ever worked with. And time came for the family to decide that it was time to let her go. She wasn't going to pull through this. And I was actually there the day that her family was ready to withdraw care, and I actually was with them when she passed away. And I remember we were meeting with the doctor that day, and the girl's father was just like, what are we going to see? What are we going to, what's going to happen? And, is she going to hurt? And I remember saying to him, I was like, I said, it's my job to make sure she's not going to suffer. I can promise you that. And he just took like a big sigh, and I don't know if those, it seemed like that was a sense of relief to him. Anyway, before it was all said and done, right before we took her off life support, we did things like I actually printed up EKG strips for her and for her family, and her brother kept one so that they could kind of have a part of her while she was alive. We did handprints. We had so many people helping us out, but I had to step away for a minute, and I had to go away, and I was just like, I need to I had to say a prayer, because I was like, just asking God, to help me help this family not see her suffer. And so we ended up, I had a wonderful pediatric intensivist with me that day. Thank God for him, because he was amazing. I had another nurse who was also with me too, just to be there. And we took her off life support, and I tell you what, it was probably one of the most peaceful experiences I ever saw. That family meant the world to me, and I've never been to a patient's funeral before, but I went to this one because I needed help kind of dealing with, talk about being burned out. I worked in a trauma unit that saw young people get hurt constantly, and it was just a lot. And I had to go to her, I went to her visitation with another nurse who took care of her, just because I needed to see how the family was doing. I needed to know that they were going to be okay, because I honestly fell in love with this family. They meant so much to me. They were so good. They were so brave and kind, and their courage was just amazing. Anyway, so I did go to her visitation, and they were very grateful that I was there. And they're people that I have kept in touch with today, because they called me a hero, and I, in a sense that, you don't feel like a hero because of the outcome that's taken place. This young girl who was full of life is no longer with us, and she had so much potential, and she helped a lot of people in what kind of took place. But I still keep in touch with them, because it's helped me sort of get kind of back in the swing of things, as far as, feeling like there's a purpose, there's a reason why I'm a nurse, and it's helped me tremendously. So these situations, even though they have not so great outcomes, can sometimes just sort of help you to not revitalize you, but help you sort of say there's a purpose why I'm here, and I'm doing the right thing, and I'm going to carry on. So take that with you. And you're not, as new nurses, as you get more experience, you're going to see it more and more, but don't be afraid to be emotional. People say you shouldn't, you should have some boundaries set, and you shouldn't get emotionally attached. No, you shouldn't get emotionally attached with every situation, but it's okay to do so with some. Because we're human, and we're not cold-hearted, evil people who are choosing to take care of people.
We're just nurses.
We're nurses, and there's a reason why we did this. It's because we care. So I feel like there's going to be some situations where you're an emotional wreck. But if this family ever hears this podcast, they know who they are, and they need to know that they're my heroes too. So I'm very grateful for them. Anyway.
Well, that was a beautiful story. And wonderful. And it kind of makes me feel awesome because we're all part of this profession that has the honor to get to do that.
Mm-hmm. It's a privilege to be a nurse, guys.
It is. It is.
It really is.
And you are just at the beginning of this amazing, amazing journey. And you don't have to be a nurse for 20 years to get to do that for a family. So I hope this podcast today has been helpful for you guys, kind of hearing our experiences and knowing that I guess we're not these like cold nurses that just do.
We're not
robots.
What's
must
that
give
nurse?
Care.
Nurse Ratchets.
We're not nurse Ratchets or nurse Jackies. I guess we're just nurse Zoes. I like Zoe from Nurse Jackie. But anyways, thank you guys for listening.
All right. Thanks, guys. Stay fresh.
Stay fresh. Yes. Check out freshrn.com. I'm going to have some links to a couple good resources about patients, dealing with patients with death, including that, blog post I wrote that got a lot of attention about kind of dealing with the emotional side of being a nurse and having dying patients. And I'll put some other resources there for you to check out as well. Feel free to check out freshrn.com for some gear and just a ton of other resources and blog posts. And thank you guys so much for listening, and stay fresh.